of it. And Dr. Stefan, if you want to know what's a textbook of sex hormone, you go to Dr. Stefan. Stefan tests his estrone estradiol is less than 2. But I believe if I have extra fat or visceral fat, I will have abnormal estrone estradiol ratio. Okay, so let's go ahead to Stefan.
Yeah.
The mic is yours, the room is yours, and this is a new session of chronic disease prevention management with Dr. Stefan Hartman. And the mic is yours, and you can go ahead and start recording.
All
Thank you
right.
very much.
I thank you for saying my labs are so perfect. Here are my labs. Okay, so this is what Dr. Halas is talking about. The estradiol and estrone is essentially the same, right? So estradiol is 46, estrone is 42. And so that's what he's talking about is the ratio. He wants it to be 1. He doesn't want you to
Less
have
than 2 is good.
or less than 2.
Right.
You don't want to have very
You
high
are more,
estrone.
you are more than textbook. You're one.
1. Yeah, that's what you want. You don't want to see super high estrone. That's a problem.
Right.
And you want to see high testosterone as well. So a total around 1,000 is very healthy. A free of 21, according to this lab, that's their reference range. So 4 to 37 is their normal. So if you can be on the top end, it'd be very good. And then we also check the pregnenolone. We check the dihydrotestosterone. We check the progesterone as well, even in men, of course. And so this is all something to monitor and very important for this lecture as well. Some of these basic labs to keep in mind when we're talking about nandrolone for chronic disease prevention and management. So this is an anabolic steroid product. And today we're going to hopefully reassure a lot of the doctors about this product, what they need to know, how they can use it, what they should be monitoring for, and who to be using it in. So, Nandrolone for chronic disease prevention and management, some learning points today. It is known to treat the anemias, chronic kidney disease type anemias, and this can improve their quality of life. They have more blood, they have better oxygenation to their tissues, reduces fatigue. It's very good for the muscle and bone. It's been, as we'll find out, it's used in a lot of wasting cachexia conditions and in the frailty that comes with ages. And then it also has a potential to reduce inflammation. So it can be used for pain management, as we'll see in multiple case reports at my practice here. But there is a bit of a medical steroidophobia. Many medical doctors, they will not prescribe anabolic steroids, and this is, a bit of a public misconception about what they are. And back in 2004, thanks to Joe Biden and the Anabolic Steroid Control Act, the public now thinks they're bad, and same do the medical doctors. It's just because they were used in the Olympics, and then a whole political thing happened, and then they were banned. And so the doctors now think that it's bad. They're all bad. You cannot use them. This is not the case. There are many medical indications for these drugs. So let's educate ourselves on the organic chemistry. You can see it's very similar to testosterone and androlone, however, is a synthetic anabolic steroid. Um, it's very chemically similar to testosterone, as you can see. It has myotrophic effects. It's more myotrophic than testosterone, so it makes the muscle grow stronger. It has this relatively nice long half-life, about 8 days. So one injection gets you pretty far. Clinical use, as we said, chronic kidney disease, osteoporosis, especially in postmenopausal women, inoperable breast cancers, and we'll talk a little bit more about why you can maybe use this in breast cancers. Used in chronic wasting conditions, age, chronic obstructive pulmonary diseases. I really like it in these conditions because, as Dr. Halassa will tell you all, you want to balance the hormones. And when you have an imbalance of the hormone, if you have a COPD patient and they are on tons of corticosteroids, what happens? Well, they waste away. They get fat, they get obese, their bone wastes away, their muscle wastes away. And why? It's because they're full of corticosteroids and they're wasting away. So how do you balance this? Anabolic steroids. Yes, say it with me here. Anabolic steroids. Testosterone, DHEA, nandrolone, all these things can and should be used for these patients because we don't want to see them waste away. And yes, Nandrolone is probably one of the most prescribed anabolic steroids because you can prescribe it today if you have a DEA license. So it is administered via intramuscular injection. Um, there is some, you hear people say you can't use testosterone because hair loss, prostate loss. Well, there's something a little bit interesting and different about the nandrolone in that it potentially can irritate the prostate, but it's not supposed to, right? It's not supposed. It's supposed to have less effect, less conversion to the DHT than the testosterone would do. So it actually might be useful for these patients who maybe are a bit sensitive to testosterone when you give it to them. But the downside of this is that because the nandrolone seems to not convert the DHT and may even block DHT conversion, they can get erectile dysfunction. There are DHT receptors in the penis too, and it helps with the erectile strength and the nitric oxide. And when you block the DHT too much, as you know, with post-finasteride syndrome, you can get erectile dysfunction. So this is one problem that men can get if they're using nandrolone, is their erectile strength can go down. If this is the case, maybe they cannot use nandrolone or they have to lower the dose a lot more. But it's a good and it's a double-edged sword there. One, they can use it if they're having problems with the prostate, but two, it's too much block of the DHT, erectile dysfunction. But there's some potential suggestions that it can even work to help these men with post-finasteride syndrome. I don't think there's been much study on this, but it's mostly a theoretical reason why it might help. Okay. More discussion on this. The lack of conversion to DHT could mean decreased hair loss in men undergoing testosterone treatment, suggesting a novel use of the medicine. Um, and we'll talk a little bit more later about the suggested treatment in joint healing and rotator cuff. I've used this a lot in patients, and that's my primary indication for using it is chronic pain, joint pain, uh, ligament tendon injuries. I had this one clinical case. This patient, he felt great, his joints feeling great, but he was getting weaker erections, so he had to discontinue the use despite the benefit he was finding for his chronic pain. So yeah, we talked about this, why it can negatively impact erectile strength. It's because there are DHT receptors in the penis. Nandrolone and joint healing. So there's a lot of anecdotal results on the internet you can find about this. So we've tested this out a decent amount. Here's a male, 40 years old. He was doing TRT and nandrolone. So he says earlier this year, I was prescribed some peptides along with nandrolone for a severe shoulder injury. He's been using it for 4 months and noticed a slow improvement in his shoulder rotation. And so we did this. The patient was doing a lot better. And now, since peptides are, very difficult to come by from a high quality compounding pharmacy like Strive, you can't get a Wolverine protocol like TB4 and BPC 157. However, you can still get nandrolone from compounding pharmacies. So this can potentially be used for these patients with chronic pains, ligament, tendon issues, joint pains. So nandrolone on muscle growth, of course, is a powerful myotrophic drug. So the hypogonadism has been associated with a dyslipidemia, atherosclerosis, cardiovascular disease, metabolic syndrome. Testosterone replacement helps hypogonadal man, and you can potentially add on nandrolone to these therapies to help these patients with the sarcopenia. The sarcopenia, I should say and clarify if you're not familiar with this. This is you see this every day in your patient practice. You see this at Walmart. This is a wasting of the muscle to be replaced with fat. This is a high estrogen and high cortisol syndrome. And these patients, if you put them through a DEXA scan or an MRI, they will have very, very small muscle and they will have a lot of fat. And this is sarcopenia. This is very common. This is, almost as bad as what some of you doctors may have seen in the HIV and AIDS epidemic, where these patients they gain a lot of fat on the abdomen, they gain a lot of visceral fat, and they lose a lot of muscle. So this is pretty much a modern epidemic that we're seeing of sarcopenia, and replacing these hypogonadal fat men with anabolics can potentially help them grow some muscle if they add some resistance training and some protein intake as well. But of course, this drug can be used for the other extreme, which is the cachexia, the anorexia, cachexia of frailty and age as well, where you have the failure to thrive with age. The older woman, she has low muscle, she's laying in bed, she's very weak, she has low blood counts. The nandrolone is appropriate to use in these patients as well. So there's been a lot of studies back mostly in the 1970s and 1990s on the use of these agents in osteoporosis, and they work very well for osteoporosis. However, the doses they were using, 50 milligrams, I think is too much, and it causes virilization. So virilization, you're going to grow a mustache. You're going to get some hair growth. Maybe you're going to get some clitoral megaly, clitoral sensitivity. We've seen this happen in patients. We'll get to some of those cases later. So a lot of these dosing protocols, I think back then there was too much. You can't give a woman 50 milligram dose of nandrolone at one time. You're going to get virilization side effects. Microdosing, however, as we'll see in some case studies, much better. So I've tailored the dose based on these studies, lower dose, longer duration of time. You're going to get the same uh, pain relief and potentially uh, reduction in the osteoporosis or even reversal of it. Here's my mother. Um, she's allowed me to share her cases here because she's doing so well. So she's had a chronic back pain for many years until I started my practice and could help her. So, we did DEXA scan. She has osteopenia, as most postmenopausal women without hormone therapy will develop. And well, she thought it was normal to have back pain. And many women will think it's just normal. Well, no, you have back pain from osteopenia. I mean, this is not good. We put her on TRT and nandrolone, and doing this has relieved her back pain. And now she can do pull-ups. She's very flexible. She can move. She can do yoga without any pain. The key has been microdosing with her. If she does too much, she gets a little bit, too much sexual stimulation. She gets some these virilizing effects. So very low dose. She only does 2 units. This is very low, 0.02 ml. This tiny little fairy dust amount. One injection once a week, or she does every 3 days. That's a good amount. She once did too much testosterone. She didn't notice ill effects. But she took a little bit too much on one time, 0.05 ml testosterone and 0.05 ml nandrolone because she didn't want to bring it on a trip. And she got actually some spotting from this. So this is a bit of bleeding, probably from estrogen conversion from testosterone or estrone conversion. So microdose better for her. This is a 52-year-old male professional wrestling coach, Olympian wrestler. This is an interesting case. He's had a lot of traumatic brain injuries. This guy was struggling. He couldn't find his way to my office without a GPS coordinates. Um, Not doing too well. So I got him on a combination of things like nitric oxide, magnesium, Cognitex, which is a pregnenolone and phosphatidylserine combo. He also is dealing with a lot of shoulder pains, back pains, really bad, limiting the amount of exercises he could do. He's getting fatter. He wasn't happy with himself. So we got him on a protocol TRT and nandrolone, also known as decadurabolin. And he said it's immensely helped his joints. He's feeling so good, he thinks he won't need to go to the orthopedic surgeon now. He doesn't think he needs rotator cuff repairs. He's doing bench press. He's getting fitter. He's getting leaner. His abdominal muscles are even showing. Um, his back issue, however, wasn't that great. He has actually a natural spinal fusion, and happens when you have repetitive trauma. It's what the body does. You don't need screws and rods. The body will do it for you, and it fuses the spine together. But this didn't help his pain, and he was still having pain. Nandrolone didn't help with that. The only thing that helped him with that is my ice bath therapy that I have at my office. So he comes and uses that. That gives him some pain relief, at least for that. But nandrolone helped his shoulder, so very happy. Here's a little bit more on nandrolone decanoate in postmenopausal osteoporosis. So again, they were giving 50 milligram doses every 3 weeks for 12 months. This doesn't even make sense. If you know about the half-life, okay, well, you give them a dose and it's out of the body in about, 8, maybe 10 days. So I'm not sure why they would structure studies like this back then, give them a mega dose and then do it every 3 weeks. But they did improve their bone. So After 1 year, there was significant increase in bone mineral concentration of the lumbar spine in the group receiving calcium plus nandrolone decanoate. So that's nice to know. Here's another one. They did 46 postmenopausal women with established osteoporosis to assess long-term use. Placebo versus nandrolone 50 milligrams every 3 weeks for 18 months. 32 of the initial 46 completed a 1 year study. So that's a pretty high drop-off rate from side effects. Overall vertebral bone mineral density increased by 3% in the nandrolone group and fell by 2.3% in the placebo group. So placebo without anabolic steroid got worse, got more frail. Nandrolone group, they got stronger, less frail, less risk of fractures. And patients with nandrolone decanoate also complained of less bone pain. Yes, we saw that earlier. Hemoglobin also significantly increased in the nandrolone decanoate group, so something to monitor for. Sometimes that can be an intended effect. So this whole thing with the joint and the ligaments issue, or a benefit, this came or was inspired. This thought process was inspired by rabbit studies where they severed the tendons in some New Zealand rabbits, and then they gave them the nandrolone. The Nandrolone decanoate administration in the phase after tendon release prevented fatty infiltration of the supraspinatus muscle and reduced functional muscle impairment caused by myotendinous retraction in this rabbit rotator cuff tail. So I think that's where the bodybuilders got the idea that it helps for joint issues, and it does seem to work. However, we have never seen a human study in ligament and tendon strength and healing beyond these rabbits. Chronic kidney disease. So yes, nandrolone is used in CKD because it helps with the anemia and it helps prevent their frailty. So ideally, you would want to add some sort of strength training program onto nandrolone therapy, but even without training, you can still see muscle improvements, body composition improvements. Nandrolone, how does that affect the hormones? Okay, so obviously you cannot just take nandrolone and expect it not to affect the natural male testosterone production because it will. Men on nandrolone therapy should also be on testosterone therapy as well because it will decrease LH and FSH. There's a negative feedback loop there. Women, potentially as well. Virilization of females is a well-known side effect. They get deeper voices, hair growth, of course. So microdosing would be better. Um, let's see. Platelet aggregation and blood thickness on nandrolone. So this is a known problem. You're going to grow more blood cells, more RBCs. Can be intended if you're anemic, of course. But if you're not anemic, things to do, you got to donate blood and maybe promote some level of blood thinning, omega-3s, fish oil. You can do nattokinase, serrapeptase, lumbrokinase, turmeric, aspirin, 81 milligrams once a week, nitric oxide supplementation, and as we'll discuss in the next slide, telmisartan. Now, why telmisartan? I put all my guys who are on anabolic therapy on telmisartan because it prevents cardiac hypertrophy, it prevents cardiac remodeling. So I do work with a lot of bodybuilders. Well, I don't prescribe them the doses they like to see. They're going to get that in the black market. So my job is to protect them from dying. So I put them all on telmisartan. Telmisartan prevents that cardiac remodeling in these guys, potentially saving them from a cardiomegaly later on in life. The nandrolone may produce a reduction in anti-inflammatory cytokines, so this can be a little bit problematic. So we add on the telmisartan. It also has anti-inflammatory benefits. We learned about that in the COVID pandemic, how these ARBs can have some effect against COVID. They're anti-inflammatory. They can even modulate the immune system. But we use it mostly to prevent the left ventricular hypertrophy. Because when you have an anabolic male who's lifting heavy weights, who wants to grow muscle, the only muscle we don't want to grow is the heart. Telmisartan prevents the heart from growing. So it makes sense to put all your anabolic males on this drug. So this study was looking at high dose anabolic steroid users. And we know a big problem with them is the increase in the left ventricular area. And this may be due to, specifically with nandrolone, it increases collagen formation in the heart, but in all the body. Now, this can be beneficial for the joints, the ligaments. That may be why people feel good. But if you do very high doses, potentially you can get some myocardial fibrosis of the heart. So what does bodybuilder high dosing look like? Now we're talking about 200 to 600 milligrams per week. Some bodybuilders will do up to 1,000 milligrams of nandrolone per week. This would be maybe in their peak cycle phase. So they're going to see some side effects doing this. Some of them don't care, or they use it for a very short period of time, as much as they can tolerate. Nandrolone is antagonistic to the glucocorticoid receptor. This is why it may be helpful in these COPD patients. So, in the short-term course, nandrolone has an overall positive effect relative to placebo on fat-free mass without expanding extracellular water in patients with COPD. In the total group, the improvements in muscle function and exercise capacity were associated with improvements in erythropoietic parameters. So they get more red blood cells, they have more hemoglobin. A use of low-dose glucocorticosteroids as maintenance medication significantly impaired the response to pulmonary rehabilitation with respect to muscle function in the lungs, respiratory muscle function and exercise capacity, which could be restored by nandrolone treatment. So we balance the cortisone with the anabolic, and in this case, it was nandrolone that was used. Here's Dr. Clearfield. I snapshotted this for him on Ehlers-Danlos syndrome. There's not a whole lot of good treatment for EDS out there, and it makes sense why nandrolone could potentially help these poor people because it can help improve their muscle mass, maybe improve their ligament and tendon strength, because that's what nandrolone does, make them more resilient to injury, strain, and pain. This is another study or some discussion on the safety of this. So the half-life and aromatization, although nandrolone can theoretically be aromatized to estradiol, it does so at a much lower rate than testosterone. This is why it's used in women with end-stage breast cancers. There's less aromatization, helps them with their pain. Elimination, the half-life is about 4.3 hours for itself, but much longer due to slow release in the intramuscular injection. So about 6 days total. The renal safety profile of nandrolone is pretty well established. It's been used in the chronic kidney disease patients. There is concern with oxidative stress if you're using very high doses of this. I've seen some labs on some bodybuilders on their peak cycle phase. Very bad labs, kind of the worst labs you'd ever seen. Very high oxidative stress, very high estrone. I mean, these guys are pushing it to the limit, and they're using massive doses. So I think the key with this is minimum effective dose. Here again, decanoate on pre-dialysis patients with chronic kidney disease. Conclusion, the lean body mass. So nandrolone decanoate expresses an anabolic effect on lean body mass without altering renal function, thus would provide nutritional benefit in pre-dialysis patients with CKD. I have currently one CKD patient on nandrolone. We've seen no changes in his renal function, and we've only seen some improvement in his anemia. Liver, so nandrolone is injectable, so it's not taken orally. So the difference is you're going to have less passing through the liver and less liver dysfunction from that compared to other things like methyl testosterone. Here's another man, a 48-year-old using 0.4 nandrolone every 5 to 6 days for shoulder pain. He says it's effectively improved his joint discomfort. This is a patient with psoriatic arthritis. He had tried to get the DMARDs. The prior authorization got denied. I fought insurance. I couldn't get it for him. So I put him on nandrolone, TRT Deca, total of about 175 milligrams per week. His arthritis disappeared. Huge. Much cheaper than that DMARD we were trying to get too. 61-year-old drywall worker. You know, I work with a lot of manual laborers. He says using DECA is amazing. He's more mobile and flexible. He actually went and tried to touch his toes from me. He said he couldn't do that before. He was very happy that he can touch his palms to the ground. He's healing faster. He smashed his toes doing drywall and it healed more rapidly. His tendon in the left hand went from a 9 out of 10 pain to 5 out of 10 pain. So, from years of holding these plasters in his hand, he'd stretch his middle finger here, holding it, and he had a huge fibrosis in his tendon here. And it's giving him a lot of pain. And he was looking at getting surgery and so forth. But we effectively dropped his pain in half with Nandrolone. He has better energy and libido, probably from the testosterone cypionate. The libido thing seems to be better for women with Nandrolone rather than men. He's not depressed or anxious. He enjoys life again. He even stopped his buspirone or sertraline. Oh no, he doesn't. He did not stop. No, he stopped these later on. He was feeling a little bit better. He started getting off and tapering off these things. But yeah, he was pretty depressed beforehand, so he's kind of worried about stopping them. I'm like, well, don't stop it. You know, just can go off them a little bit later. So his shoulder is very strong now. He used to have a rotator cuff in the left. The DECA strengthened it, where he no longer has problems. He had to get right shoulder surgery repaired to get it to feel even close to what the left shoulder feels like just on the DECA. And his toenail fungus resolved with iodine, but that's another lecture. 56-year-old asthma since age 5. Now this poor lady, I mean, she is the buffalo hump. I mean, she is a moon face. I mean, she came to me on decades, a lifetime of high dose corticosteroids, budesonide, I mean, you name it, prednisone. So we experimented with a lot of things here at CDPM Group. We tried oxytocin, ivermectin, amlexinox, methylene blue. None of these things worked for her asthma. She was having asthma attacks, 3, 4 times a day. What we did, she came to me, we replaced all her hormones, estradiol, testosterone, progesterone, pregnenolone. We did the whole thing. And her skin was improving from the dryness. However, the asthma kept persisting. So what did I do? I put her on oxandrolone troches. That's another lecture for her osteopenia, osteoarthritis. This improved her asthma as well as an unintended effect there, where she was only having asthma exacerbation 1 to 2 times per week. However, oxandrolone at that time became harder to source, so we went to nandrolone, zero point 0.5, so 5 units injection weekly, and rapamycin. She started taking this. Now, I wrote the rapamycin prescription. Take one only once weekly. What does the patient do? She takes it every day. So she took rapamycin, 5 milligrams every day. And I texted her, like, what's going on? Are you better? She's like, yeah, I don't have asthma anymore. I'm like, oh, wait, just once a week? And she's like, no, I've been taking the rapamycin every day. I'm like, oh, well, you're not supposed to do that. So just see if you can get away with it like once a week or occasionally use. So um, yeah, she was, but also she was not using 5 units. I mean, I don't know why maybe she has bad eyesight. She can't read. Instead of doing 5 units, she was doing 50 units of Nandrolone a week. Oh God. But no virilization side effects occurred. She started doing resistance training, more HIIT training because she can tolerate now. She had exercise tolerance, and she only got one bad asthma exacerbation during intercourse, which that is a new activity for her because she was not doing that because she was feeling so terrible. So feeling a lot great, a lot of new things happening for her. Here's some of her labs. As you can see, no problems on the kidneys, no problems on the LFTs on such high doses of nandrolone. Calcium looks fine. White blood cells still elevated, 6.4. I mean, that's chronic for her, so long on corticosteroids. Um, and then here's a little bit more from mom. She's very descriptive. She's one of the best patients I have because she's very analytical, like how these things affect her. She pays attention to the doses. She's not giving herself overdoses and not paying attention. So she's very good. Um, let's see. Let's see, mom's chart. Particularly great mood with Nandrolone. Workout is great. She's only injecting 1 unit a week. Good. Easier. Workout is easier. Recovery is easier. Muscle building easier. Feeling confident. Feeling sexy. Great. That's all. And then, yeah, I had two other patients. They also did the same issue. Instead of injecting 5 units a week, they were injecting 50 units. These two did have some upper lip hair growth. So, in summary, my point is use minimum effective dose to relieve bone pain and tendon pain. This drug seems to have less side effects in women when used at a microdose. In men, sometimes it can be great. Sometimes they get the erectile dysfunction. If you give a man erectile dysfunction from Nandrolone, he won't be happy. So it's a no-go for him. They got to stop it if that happens. But for some men, great. They don't convert to DHT and they're fine. Or the issue is the problem with the Nandrolone doesn't but the suppression of DHT from Nandrolone doesn't affect him. I should just point it out that way. It's just luck of the draw for some guys. So that's all I have for you guys today on Nandrolone for chronic disease prevention and management.
Great presentation, Dr. Stefan. And we need to reason why nandrolone does help patient with asthma. And we all the time, me and Dr. Joseph James, especially, and who are adapting Cyrex lab, we test or we ask the question how nandrolone affected Th1, Th2, and Th17, because that gives us understanding of how this drug works. Because you said it's working for asthma, and we know it's a metabolic drug.
I
And,
think I
uh,
think in that patient's case, she was accidentally overdosing on rapamycin. And rapamycin does affect the Th 17, does affect the immune system. I think that's what did it for her.
well, no, no, really, I'm reading from here. The nandrolone is an anabolic steroid, and it's believed to have a potential to suppress the developing infection of Th2 cells.
Huh.
And that's the reason.
Uh-huh.
So basically, if anybody has allergy or shift into Th2 and Th17, then nandrolone works as anti-allergic, and that's a good thing because you can use it for cancer now. Anything inhibit the Th2 and Th17, that's mean it's polarizing the immune system to Th1. That's mean it has a potential cancer anti-cancer effect. And now it's working for allergic, so that's mean it's good for infection as well. Because anything polarizing to Th1, anything inhibited Th2 and Th17 is good for viral and intracellular pathogens, including virus and cancer. Um, so anything that can have Th2 and Th17 is good for cancer and allergy and intracellular pathogen. So it's good, but it's very clear it suppresses the Th2. That's the reason. And you maybe rapamycin as well, because it's an antibiotics. It may kill any hidden intracellular pathogens, but it could be it inhibit suppress Th2. But I need to check that.
Did you
But that's very interesting.
did you say killing of intracellular pathogens? Rapamycin?
No, no, no. When you inhibit the Th2 and Th17, then you are polarizing automatically the
No,
immune
no,
system to
no. I
Th1.
mean, I heard that part, but I thought you said that there
No,
might
no.
be
Well,
some
indirectly,
anti-pathogen or
no,
antimicrobial
no. If
action from the
you
rapamycin.
enhance to Th1, if you inhibit the Th2, that's mean you're polarizing the immune system to Th1. And if you polarize the immune system to Th1, that's mean you are producing cytotoxic T cells and you're enhancing the immune system against cancer and any intracellular pathogens infection, which is mycoplasma and viral infection, anything that's intracellular.
Okay, no, that's
Indirectly
perfect.
for the
And
immune, directly killing the bacteria or the virus, but it's polarizing the immune system to Th1. And so that's a good thing for allergy, and that's also something about Dr. William talked about a case that also has angioedema. Maybe nanodrolone will be another ingredients he can add to his equation. I know, Dr. William, are you there? We're gonna meet soon. But he has a case of angioedema and he's looking for things that inhibit the Th2. And I send him a list of antioxidant options.
Yeah, I'm here.
So nandrolone may be the answer for your patient as well.
Okay. I'll try and. Where do you source it from?
Our
Well,
friends here, Strive.
I'm having trouble with that. I don't know about you. Every prescription I write, they call me. They said there's something wrong with it. Every
Yeah.
single.
who's that? Strive?
Yeah, I've had that too.
Every,
Really?
Every single one.
Oh,
It
well,
must be they're meticulous, maybe.
Yes.
No, because I do them electronically. I mean, every other pharmacy takes the exact same ones. I don't know what's I
Oh
don't know.
no, don't do it electronically. They call me nonstop when I put it through the EHR. You got to put it through LifeFile.
Uh, I can't get it.
Oh
I
yeah, that's
put
right. Your IP address is wrong. You told
I
me.
got I got a VPN and I can't find it and I can't get it off of there. It tells me
Ah,
I'm in Brazil and
yeah,
it won't
no,
work.
that's too bad.
So
Any other
anyway,
comments about Nandro?
Yeah,
We had a
yeah.
question.
I had a question. The big one is, and maybe you answered it and I didn't hear it. Is there any conversion to estrogen? Do we have to look at estrogens and
Uh,
be concerned about that?
Much less. There's much less conversion of nandrolone to estradiol. You should still monitor it, but it has been used for end-stage breast cancer because of that very reason, less estrogenation.
Interesting. Nice lecture, by the way. Very good.
Yeah.
Oh, and congratulations on West Palm Beach. You helped to change the laws over there,
Oh, yeah,
getting
Palm
fluoride
Bay.
out.
Palm Bay,
Palm Bay,
yes. Yeah.
getting the fluoride out of the water.
Yes.
There. Yeah, no, congratulations. I saw the video.
Yeah. There's a question on the dosing. So if a woman is on TRT, adds DECA, what's the dose of each? So 1 milligram topical testosterone a day or less. If you're doing an injectable TRT, you want to do very low dose, maybe 2 units, because it usually comes in a 200 milligram vial, so maybe 1 or 2 units a week. And the same for Deca or Nandrolone, maybe 1 or 2 units to start. So you do a microdose. You can draw them both together and inject the 4 once a week. That's enough. And then the question was the dose for men on TRT who add Deca. Again, very little. So you do the TRT as you normally would with if it's a 200 milligram vial. So um, it's 200 milligram per ml. You give them like 0.4 ml testosterone injection every 4 days. That's usually how I have men do it. Sometimes a little less, sometimes a little more. Then, if you want to add nandrolone, you reduce the dose of testosterone a little bit. So, if you want to add a unit, or if you want to add, 10 units of DECA, you would reduce 10 units of testosterone. And that's how I would start it for them.
How about going with nandrolone? Say for me, um, go for nandrolone and the progesterone, and that's it. And forget about the testosterone.
Yes,
Any okay?
you can do
well, it
that.
doesn't cause suppression of central
Yes.
HRT.
Yes. So
Yes, it does.
typically men are always on a base of testosterone because nandrolone has the same suppressive effect on natural production of testosterone as testosterone therapy does. The issue with nandrolone only therapy in men though is you get no DHT. You get a blocking of the DHT. So you get the same effect you might get with taking finasteride, which is you can get a loss of erectile strength. This is a big problem. So
Oh, forget about
the dose the dose needs to be balanced. You should probably always have them on testosterone, and if they're getting an erectile issue with nandrolone, you either stop the nandrolone or you back off the dose a lot. But the same does not apply for women. Women get hypersexual if you give them a little bit of nandrolone. I mean, they love it.
Right, right, right. So here's the Dr. William Clearfield. I just searched it. Nandrolone deconate is non-17 alpha alkylated androgen that can be used to treat heredity angioedema. So I think you got the answer for that for your patient. I don't know if she's heredity angioedema or the kind of angioedema, but
yeah.
you know,
Okay.
right. I don't know about rapamycin. I'll look if it's inhibiting the Th2, but I think it does. I will see, and I think it will. The other thing, I have a question for you, Doctor. Uh, so nandrolone does not convert. How it's metabolized does not convert to. It does. It's not. Does not aromatase to estrone, right?
No, not much. Much less than testosterone.
So how it? Do you know the metabolism? What happened to the nandrolone? Because we need to know. What's the byproducts of it.
So it's excreted through the urine, and
As
half
it is, or as a metabolites?
the here, I'll pull up the slide again. Hold on.
And any side effects of the metabolites?
No, no side effects of the metabolites. Nandrolone binding to the androgen
So who's
receptors.
metabolizing it? How it's breaking down? How it's being treated? I'd like to know the pharmacokinetics of it.
I thought I had that
Does
written
not convert to estrone, right?
here. Let's see. Here it is. 5-alpha reductase can also act on nandrolone to produce 5-dihydrotestosterone. This reduced form of nandrolone has a significantly decreased binding affinity for the androgen receptor compared to its parent steroid testosterone. As such, 5-alpha reductase conversion of nandrolone to 5-alpha dihydrotestosterone in prostatic tissue results in significantly decreased ability of nandrolone to bind to androgen receptors. So theoretically, the end result could be a decrease in prostatic growth with a possible and theoretical effect on lower urinary tract symptoms, such as the BPH and the alopecia.
Well, as long as does not convert to estrogens, I think it's a good thing. And as long as the metabolites does not cause any side effects, or the body can get rid from it. So why it's being banned, or why they don't like it here, or what's going on?
Oh, it's not banned. You can still prescribe it. It was just banned in the Olympics. That's all.
Okay, so for medical use, you can prescribe it still. So it's not.
Yes.
Okay, great.
And I was going to say, so maybe perhaps a low dose,
Yes.
being very conservative would give you all the good benefits. And if there's concern of negative feedback on the pituitary gland, maybe having on board the enclomiphene to
Yeah,
block. Yeah.
I've never tried that out. I just tell men if you're gonna do any injection, I mean, your natural is gonna be decreased. I don't think there's like a micro dose. Maybe I've never tried that out
Well,
before.
I guess what I'm not saying is microdose, but as opposed to, like, I've moved away from the old concept of testosterone. Well, I wouldn't say it's the old concept. It's what I saw a lot of is relying everything is testosterone, for example. That just the mentality of the population. It seemed like that's what was going on. And then as I tried to do testosterone again over the past 6 months, it was like it just turned straight to estrogen, in my body. I could see the estrogen dominance like right away after doing the injections.
I see.
So I changed my philosophy to hormone balance and focusing more on making sure that my estrogens are balanced and started focusing more on progesterone. But now when I hear this lecture, it makes me think maybe there's a place to move a little bit back in the direction of testosterone, but this would be maybe better, but just at a low dose because there may be some great effects, unintended great effects from shifting the immune system, maybe helping with brain fog, things of that sort, increasing energy levels, physical activity, things like that. And when I talk about physical, I'm like exercise physical, that may create a positive reinforcement, meaning that the exercise, we reap the benefits from the exercise, like you clearly do, that and all the things that you do. But and those are just thoughts. Maybe there's a place for, you know, outside of just cachexia, which is, I understand that might be the more um, best place to talk about it, but maybe there's a place with hormone optimization as long as it's balanced out with progesterone instead of testosterone.
It's
That's
worthwhile. I'd be curious if you did it. It's not supposed to have such estrogenic side effect profile as testosterone. Try a microdose and see how you feel.
okay. Awesome.
What is
Thank you.
your testosterone? Depending on testosterone level, did you got into 1,000 or not to 1,000?
Me?
Yeah.
Well, I mean, I was like Hartman. I had My testosterone was like 1080. Are you talking about after I started taking the oh, recently? Well, I never checked
Just
it.
recently check the whole thing and make sure you check the estradiol, estrol, so that you are giving yourself things based on data that you have. Because if you got the 1000 level, then what you're doing is great.
No, no, this was
Right,
maybe five years ago. I was at that level,
right.
um, or actually maybe 10 years now that I think about it. But I was just saying, you're right, and we don't know. I didn't check, but
Because I need to
I
check
could
myself
visibly
too.
notice the estrogen, and I wasn't doing like extreme dosing. It was just your average dose. But that was just, again, it was just a clinical thing. It was like, wow, this is not it seemed like it was turning straight to estrogen. That was just I was hyper aware of the fact, and I thought, you know what, maybe testosterone isn't the thing. Let's focus on the other ones, and maybe the enclomiphene, and overall health, and maybe let's stay away from testosterone. Maybe that's a losing game right now because we're just polluted, too
Yeah.
polluted.
Well, you
Yeah.
you used to have some toxicity issues, right, Dr. Joseph? Is there
You
any
used
chance
you
that you
you
had
used
a
you used to.
is
I
there
wish.
any chance you had an overload of xenoestrogens and that was part of it?
Part of of my
Yeah, part of
non-ending my Gulf War syndrome. I mean, I mean,
it.
COVID, the long COVID. um
I mean, toxins, because you
yeah.
checked everything and you made sure
Well,
100% it was the testosterone
oh,
converting.
no, that was just an observation that after I would do an injection, the day or two after, it was as if I was developing estrogen dominance. It was like, it's just everything became softer, if you know what I mean.
Hmm.
And very quickly I was like, without even checking the level, it's like, I think this is just
You
turning
could
to
feel
estrogen.
it.
Let's just, right. As far as toxicity level, I'm going to do a full panel, uh, just to have more information. But I will tell you one thing. Now, this goes back to the retrovirus example. And just to make sure that we are on the same page, we can't, I'm not saying that this is the only thing and there's only one way. This is an epiphany and of something that is playing a bigger role than, and maybe didn't even realize is playing a role. But the thing about long COVID is there is plenty of data now pointing towards the fact that COVID, either by itself or through activation of Epstein-Barr, is triggering the activation of a certain endogenous retrovirus. Okay, um, I believe it's the it's they call it HERV, HERV, not herb, not herb, but HERV is in Victor, W, and it produces a just a piece of itself, which is really just the capsule, I guess, a piece of the capsule of the virus, and that's serving as a super antigen. That's what they call it. That is triggering excessive inflammation. Now, that may be the same thing that's triggered in psoriasis in general, but when it's triggered in the brain, it leads to chronic neuroinflammation. Now, when they're on, for the most part, they're on. They don't just shut off. And the reason why I bring that up is that that's another avenue I think we should explore, because it may be that the reason why, think about it, somebody who has an autoimmune disease, why doesn't it go away? Why do they have it? Is it possible that it's activated, or why do they get it sometime later? And why is it sort of a um, genetically, or you get it, one of your parents has it, or it's picked up from your family line? Well, is it because you have the same retroviral profile, profile in your DNA? And it may not be activated, when you're 10 years old or 15, but it may become activated when you're 30 because it's activated by a pathogen in many times. It could be mycoplasma, now that I see mycoplasma as an intracellular pathogen,
Hmm.
chronic, okay, that triggers the cascade of events that leads to the turning on of the retrovirus that, depending on the situation, will conduct the orchestra of the disease process that you're dealing with, whether it's psoriasis or rheumatoid arthritis or cancer. Okay, so that was the reason why I keep bringing it up, is because I think it's the next level of understanding for us to look at when we're looking at these these syndromes that don't seem to go away. Well, just like an autoimmune disease, they don't just go away. Why? Because a gene has been activated and it's turned on, and um, and it's not junk DNA. That's fallacy. It's endogenous ancient retroviruses. At least that's what they call them, which is completely off topic. I understand, but I just had to get that one out there.
Hey, I
No,
got
well,
a lecture on Wednesday more on mycotoxins. I got that one with the
Okay,
Harshfield group.
so rapamycin is inhibiting of Th2 proliferation. So you did everything in the book.
Okay.
This is a new thing we learn about rapamycin, and we know rapamycin is good for cancer, so that's for sure. But that's the reason your patient is you're giving her immune modulation and you're inhibiting Th2 and Th17
Yeah.
from the core, right? So it's better than cortisone and better than anything out there because you're doing it without the side effects of the big pharma products. So you can be specialize it as immunologist. You can be, I mean, come on, you're better than immunologist right now in managing allergies
Yeah.
because those allergy patients they fail. I mean, I can see people with eczema and all that stuff. Those doctor they call themselves immunologists. They fail miserable in managing allergic diseases.
Yes.
And now you have a solution there. I mean, but how we can take this to the next level, we need you to get recognized and all that stuff. And we need to translate this into, which we have Dr. Mike Emanuel here too. It's a compounding pharmacy.
Yeah.
Mike, go ahead. The mic is yours, Mike Emanuel. We're talking about nano.
Mike, I have great
Hi.
story for you, man. You're doing amazing work with your intranasal progesterone and cyclodextrin. I had another patient tell me today how it's been fantastic for his sleep.
Yeah, we have good results. A lot of patients are refilling their prescriptions. They say it's working.
Yeah, it works for sleep very well.
Thank you. Yeah, we can make any type of medications, customize it, and I'm gonna post my email address on the chat for if anybody is interested to send a prescription for their patient. But it's
Yeah.
working.
Yeah.
So I'm gonna post my email address and information.
Yeah, I gotta follow up with this patient before. I mean, I was not intending to have her take rapamycin 5 milligrams every day. I mean, that's a pretty high dose, but
Oh,
it did work to make her asthma stop. And
wow,
she has had asthma exacerbations like every day for like
wow,
years.
Hey, that doesn't surprise me. And this is not the first time I've seen that happen where we are accustomed to this idea that, wow, what would happen if somebody overdosed on some of these things? And what I'm not saying is take as much of anything as you want, but I've seen it before where somebody makes that mistake, like with Clotho. There was a football player with a history of 20-year history of he had a head injury with some peripheral vision loss, post-concussive syndrome. He was getting hyperbaric treatments, and he received a bottle of Clotho for which he was supposed to start off with, maybe 20 units or 50 units. But it was a 10 milliliter bottle, and he injected the whole thing.
wow,
The
Nice.
whole thing is literally, and within a week or two, his peripheral vision started to improve, and he was just feeling fantastic, with no
wow.
no downside. So sometimes it makes me wonder if we have a lot more wiggle room with these approaches than we think, and we don't realize that we may actually have results beyond what we ever would have expected with higher doses. Again, I'm not saying we'll just go do whatever and try anything, but it's the mistakes that patients have done that have taught me,
Yeah.
wow, they got the best result,
Yeah.
and that says something.
Yep. Thanks. In the name of science, thank you.
Yeah. And rapamycin, I'm actually more and more interested in it because, when I think about it, when I look at the perspective of when you're having lots of dysregulation, and say it's dysregulation that's hard to get rid of. Like I said, there's a button that's been pushed, and it's not easy to turn off that button. Well, it may be that some of those cells they need to go. They are basically like senescent cells that are dysregulated and only contributing to the problem. And that if we can shave or exfoliate, I like to say exfoliate from the inside, those dysregulated cells, not just senescent cells, but cells that are dysregulated because of all of the dysregulating issues that we're being filled with, that is a big piece of the puzzle. Exfoliating these dysregulated cells or helping to get rid of them. Just a thought.
Yeah. Yeah, it's possible.
Very good. All right, guys. Is that it for tonight?
I feel pretty good. Good lecture, man. It's really good.
Yeah,
Okay,
thanks, Stefan.
everybody. Well, good night. If there's anybody question, you come up.
It's
Tano, do you have any question? We'll see you in Vegas,
no Vegas,
Nevada. Sorry. I
Nevada.
didn't.
I'll be doing Zoom lecture for them. I'm not
Hey, come
going
on,
there.
man. Jump in the car, flight, you and your wife, and just see you there.
Come on, with what money?
2 days,
You
2 days.
you spend
You're
it
not
all.
even working.
You spend it all in Italy.
I spent it all in
Yeah,
Vegas. Vegas cost more than my trip to Italy.
that's true. That's true.
Dr. Halasa, you coming to South Lake?
I'm coming. Yeah, I'm coming to you, man. I cannot miss it. Well, I'm coming with.
Don't get too excited. This is real medical doctors. They sign in and go skiing.
Really?
Yeah, yeah. In the main lecture, if I'm lucky, I'll get 20, and in my side lecture, I'll get 4. I
Wow.
told you I use it for practice.
Well, that's fine. We can just go ahead and ski with them.
Yeah, I gave up skiing a long time ago. So
Oh.
Right.
one false move and I'm not
Is it
moving.
cold? Is it cold there?
Yeah.
It's Reno, where I live. It's not bad. It's 50s, but it's an hour away. It's the lake, Lake Tahoe. It's snow. You got plenty of snow.
So I have to pack my clothes with all the big stuff.
Yeah, yeah. You need a coat.
Okay.
Yeah,
All
this
right.
isn't Florida.
Yeah,
Uh,
no,
yeah.
no. It's the opposite. They have
Yeah,
ski.
I'll make sure I fill up my bag with clothes.
They had the Olympics there. One year. So this is a big time ski area.
Yeah, it's gonna be fun, right?
Of course, it's going to be fun. Right?
Yeah.
Right? You're going to be here. How could it not be fun?
Well,
Yeah.
well, you are there. That's why it's fun.
Yeah. Oh, yeah.
Yeah, I mean, there's like cracking jokes and stand-up comedy thing and things that you do.
Yeah, we do. We do all that.
Really, that's
Yeah, and there's
actually why I'm going there.
yeah, there's a
But for just
karaoke
if you
night.
want to come and jump, get your
Dr.
flight and
And
jump
Fonz
2 days.
is a Dr.
yeah,
Fonz.
I might have to go there and make sure you don't hurt yourself on the ski hills. Maybe start
Well,
off
come
on
on, come on.
the bunny
I
hill.
have the queen bed double too. So don't worry, just get the flight and come. Jump.
I know.
All
We got
right.
to do it. We got to do it like we used to. Remember, we used to just.
No problem. If you want to come, just seriously, I have the queen bed. You don't need to book anything. Just get your flight and come.
All right.
Okay?
Hey, it sounds fantastic. I might take you up on that one.
All right.
Okay.
Yeah.
You said
It,
extra queen bread, right? Bleh, bed. Just go ahead.
it's a fun place to be, and there's lots of stuff going on all over the place. But it is cold. It's winter there.
Oh man, I left
So
that a long time ago.
yeah, I know.
I know.
Well, it's only a couple of days. You can survive it.
Are you coming, Joseph, or no? Are you seriously coming?
No, I'm. When's the date? When's the exact time? What
My lecture's on Friday. If you can come Thursday
Thursday?
to
I'm
Sunday,
doing Thursday and Friday.
Thursday and Friday, right?
Yeah.
And
hmm
there's Saturday or Sunday or no?
Saturday, I think they go to Saturday. They start on Wednesday. They always have ACLS
It's a very
classes.
long one.
Yeah, plus there's
Just
CME.
come
So there's CME.
Thursday. So if you want to, because you have patience.
Are there osteopathic specific hours for this one?
Sometimes they do,
Yes, and they
sometimes they
have
don't.
AOA certificate.
Yeah, no,
Yeah, you get an
that
AC. You can get an ACL, advanced life support.
yeah, those
So
things are. Sorry
You
to
need
jump in
those
there.
AOA, right?
yeah.
Yeah, no,
Right.
it's important for the
You need it.
osteopaths to grab specific osteopathic hours because they don't count towards the osteopathic license. I mean, we can have any kind of MD, CME, but there's always a certain amount of osteopathic hours that some states more than others, and so for
Hmm.
that reason, that's I mean another motivating force to try to
Yeah,
jump
come
on an
Thursday
airplane and chance
and
getting
leave Sunday.
what's that?
Come Thursday and leave Sunday. I'm leaving Monday, but you have patience, so Thursday to Sunday, it's good for you.
Yeah, like I said, I'm feeling that spontaneity, but like I said, let me let it sink in, and you never know.
If not, you
That's
can come
something.
visit me, Dr. Joseph. I'm creating low zero EMF room for you at my office.
Is it
And
in a closet? Like
no, it's gonna be a room, no Wi-Fi. It's near the river. There's no electronic signals around the place.
oh my goodness.
Perfect for you.
Yeah, no, exactly. Yeah, that sounds amazing. And you're gonna and all the good stuff.
Yeah, you can do cold plunge and sauna and red light therapy. It'd be fun.
Yeah, man, I'm liking
Are
all
you
these different.
stealing him from me or what?
Yeah, I'm stealing it from you.
Okay.
Well, obviously I can pop up there, got more flexibility to pop up to Melbourne. Actually, I've always been curious about the place, but no, this is great, guys, and that's the cool thing is making all this stuff we do fun and having adventures and stuff like that. So yeah, just listen out for me because I'm feeling it.
That'd be fun. Come by. We'll do the lecture, the CME for them, and then I actually have a tennis tournament that day. That's why
Oh, okay.
it's a tournament I got invited to in Vero Beach.
So is this like more of you're just making an appearance like
It was an invitational event, so all the pros in the area get invited to compete in this playoff, and so it's that day, Thursday.
oh, that's that's awesome. Is it tied into is this tied into the or the fluorine water issue, or is this completely separate?
Completely separate. These guys have no clue about that.
Yeah. Yeah.
You do. But these
Thanks to you.
osteopaths, they're about to get a dose of that medicine when I give my lecture to them.
Yeah,
Is it
don't expect a warm, fuzzy reception. In fact, I gave a lecture on testosterone in women, and I got lambasted like nobody's business. So
Oh man.
these are the right white. I call them the white bread medical doctors. They're not exactly up on what we do.
Okay.
Okay,
Mm.
so but like I said, I mean, it's an opportunity to talk. You get some new things. We always pick off one or two new people. So,
Okay, good.
um, but just don't expect the like it's not an A4M. It's not a Halassa group. It's not our group. They're they're most of all actually they only go they go to they sign in and they go skiing all day.
Ah.
So they have classes from 6:30 to 9:30, and then they come back at 4. So
No, I used to go to there was an osteopathic one, well known actually amongst the osteopathic community. I mean it was a mix of MD and DO, but it was from the College of oh, it's in what's the mountains in Colorado, Breckenridge.
Hmm.
And every year they would have the conference, and it was like tradition, but it was like they had it even set up that it's okay. We do your classes. Okay, now everybody can go skiing now, and then everybody, they'd be dressed halfway into their skiing gear and the whole thing, and it was quite interesting.
yeah, well, um, this is actually how I got. I was still living in Pennsylvania, and I went to one of their conferences in. It was in 2002 in Las Vegas. It was a big trip to go from Pennsylvania to Las Vegas, and the time change and all. And it was so awful. I left like everybody else did. But I went across the hall. There was another lecture going on, and it was Neil Rosier talking about hormones, and that's how I got started with this. So,
And interesting.
yeah. So it was one of those. It was one of those right place, right time things. I think.
No, that's fantastic. Actually, you made me think of when I first went to the Breckenridge conference. It was actually for specializing in musculoskeletal ultrasound, and I was already immersed in regenerative medicine. In fact, I was just sort of hijacking the CME for my own purpose in the training because I was doing more and more PRP and stem cell injections, and this was in 2017, maybe even late 2016. And I remember dealing with even one of the guys there was immersed in the field too. He got it and understood it, uh, and was I had treated his parents, and he was introducing me to people and telling me some of the things I had done, and you would just not believe the arrogance people had. It was just kind of like, oh well, there's no evidence to support that, and I remember one of
Well,
them.
every time I give a talk, don't isn't that what I always say? Yeah, my doctor says there's no evidence of fill in the blank, so that's always my theme.
Right, right. And one of them just sort of patted me on the shoulder. He said, "Yeah, that's interesting. I guess that would go along." This was an MD actually. She said that's interesting. I guess that would go along with osteopathy, like PRP and you know um, manipulation and manual treatments and stuff
Mhm.
like
Now
that.
run
And
along, Sonny.
right. Well, the funny thing is they actually the next year they actually changed their entire curriculum to a regenerative. They actually immersed it or